Hi everybody! Welcome to today's recording. I had a very interesting journal article come across my feed in the last few days that was discussing the role of point-of-care ultrasound in nephrology. I think it's interesting for us as anesthesiologists to see how this point-of-care ultrasound is expanding into other specialties, and some of these skill sets are things that we can use even within anesthesia. Here's a summary of the following paper. We're going to review Pocus in nephrology, a new tool to improve our diagnostic skills. That was published in February in the Clinical Kidney Journal. So there's a few things that they suggested where point-of-care ultrasound can be helpful in nephrology. Looking at whether there's stones, significant hydronephrosis, bladder scanning, assistance with renal biopsies, and then in the assessment of AV fistulas, you can look at whether it's safe to create an AV fistula, whether there's high flow in a fistula, and also looking at the maturation of these fistulas. None of those are really particularly helpful to us, but then the next step, they really focused on the assessment of congestion. And I think for us as anesthesiologists, this is a key thing. So they started off by discussing that heart failure generally presents as congestion. So there is a small group that presents with decreased cardiac output, plus minus congestion. When you have a heart that is failing, what you will see initially is an increase in hydrostatic pressure, so vascular congestion, and then that will proceed to interstitial edema or tissue congestion. Congestion, though, is more than just edema. So we think of that often as that edema, the pitting edema that we get on the ankles. But really there's more to it than that. So in vascular congestions, what would happen is that pulmonary and cardiac filling pressures would increase. And that has a significant effect on the rest of the body. We get the renin, angiotensin, aldosterone system activated, the natriuretic peptide axis, and we also get the peripheral nervous system activated, which causes vasoconstriction and diversion of blood flow from abdominal to the systemic circulation. As we get more and more tissue congestion, we get this peripheral overload, and that causes global congestion with harm to other organs. And it has a whole body impact. In central nervous system, we can have cerebral edema and delirium. In the respiratory system, we get pulmonary tissue congestion, pleural effusions, pulmonary edema. Hepatic congestion can cause impaired in synthetic functions. Gastrointestinal system, we can have ascites, bowel edema, malabsorption. In the cardiovascular system, myocardial edema, conduction disturbances, and diastolic dysfunction. And this honestly wasn't something that I had really thought about before, is that fluid overload actually has an effect on the heart itself. And then the next one was also very interesting to me, is that during cardiac failure, the renal system is probably more affected by congestive nephropathy than by poor cardiac output and poor perfusion of the kidney as a cause for a lower GFR. How do we find out if a patient is congested? So the assessment for that has to be more than clinical. We can't just do an assessment of peripheral edema and say yes or no, this patient has congestion. We know that there are some biomarkers. The one that you guys are probably mostly familiar with is the NT-proBNP. There is also the CA125, or the carbohydrate antigen. I do not know if this one is actually widely used. So it does show a positive correlation with severity of renal vein congestion and has become a surrogate marker of tissue congestion, whereas the NT-proBNP is more a marker of vascular congestion. How can ultrasound help? The wide application of ultrasound will bring us to the diagnosis of 4 phenotypes for congestion. So firstly, you can say no congestion, then predominantly tissue congestion or vascular congestion or mixed congestion. And how do we make that assessment? Focused congestion assessment is more than looking at the IVC. Now the IVC is still important. We look at the intrahepatic portion of the IVC, about 2 centimeters from the junction with the hepatic veins. We look at the size of the IVC and the collapsibility during spontaneous respiration. But there's more to it than that, and there's more that we can do. We can look at hepatic vein flow and portal vein flow. Hepatic vein flow is interesting. The normal pattern of hepatic vein flow will have forward flow during systole and diastole, which correlates with the X and Y descents on your CVP trace. The only time when there is not forward flow in hepatic veins, as well as pulmonic veins, is during atrial contraction. And you can see that little peak there, peaking up above the line. As our patient becomes more congested and atrial pressures rise, the X descent gets blunted, and therefore the negative S wave becomes less deep than the D. In even worse congestion, the S wave can turn positive. Looking at portal vein assessment, we're going to look at pulsatility. In normal conditions, there's no or minimal pulsatility that increases to about 30 to 50% in mild congestion and more than 50% in severe congestion. So to summarize, this is what we would look at. We would look at IVC, diameter and collapsibility. We would look at hepatic vein and specifically at the S component. So what happens during the systolic phase of the cardiac cycle? Is that S wave bigger than D? Is it flattened or is it reversed? Congestion assessment will include scans of the lung. What you would be looking for would be pleural effusions and B lines. I will post a link to a video that I've made on lung assessment for a better understanding of lung ultrasound, should you be interested in pursuing that. You'd also do a full cardiac scan, of course, to look at whether there's any significant cardiac contribution to your congestion. How do we treat congestion? So I think for us as anesthesia, we really want to focus on knowing when this vascular congestion portion is starting to happen, because we can possibly target treatment and prevent the development of tissue or global congestion. Not always, but possibly, especially if it's related to the care that we're giving on the potential fluid overload or cardiac failure within the operating environment. Vascular congestion, we would treat in the acute care nitroglycerin, inotropes, and of course always diuretics. Tissue congestion is an interesting phenotype, and there is now more and more information on the role of sodium glucose cotransporter inhibitors, the gliflozins, in terms of decreasing congestion with minimal effects on vascular tone, unlike loop diuretics. Controversially, if you have tissue congestion with vascular depletion, there is also some suggestions or some literature that suggests albumin infusions in hypoalbuminemic patients or hypertonic saline infusions. I wouldn't suggest that you go there, but it might be interesting reading to look at some of that in more detail. For global congestion, so vascular and tissue congestion, the go-to is still loop diuretics, and those with diuretic resistance, and especially those with low urine output or low urinary sodium excretion. We can use strategies such as sequential nephron blockade and ultrafiltration. I'm not going to discuss those in detail, but they are there for your reading if you're interested in looking at more detail. Two concepts that sort of came from this paper that I just for further reading is the concept of pseudo-worse renal function or permissive acute kidney injury, where you allow the creatinine to rise during diuretic treatment in patients with congestion or edema. As some of the research suggests that creatinine elevation during diuretic therapy are not associated with structural damage and could be related only to functional disturbances. So just a few things to pique your curiosity and to show you how point of care ultrasound is now moving to other specialties. The focus of this was to look at how can we use our ultrasound more to look at congestive heart failure patients in terms of assessing them for tissue and vascular congestion to target treatment appropriately. Thank you very much for listening. See you soon in the OR. Continue to focus on your Pocus.